Good evening, all the aspirants present here. So, the topic for today is brain death and organ donation, and it is a CBS session. All the students are requested to kindly mute their mic and always unmute when it's required. If any doubt, any question, please drop it in the chat box, and it will be an interactive session. Thank you.
Yeah, so is it visible in slide share mode?
Ma'am, it's not visible in slideshare.
It's always why I don't know. This is the problem. I'm
Uh,
doing slide share only. This is the slideshow mode. So right now I'm in a slideshow.
okay. Ma'am, aspirants, are the screen visible to you?
Yes, the screen is visible, but not in slideshow like you pointed out.
Yeah. So, ma'am, I think we can start like that because
Yeah,
it's not in the
because
slideshow. Okay.
yeah, from my side
Okay.
it's slideshow
And
only.
okay, it's fine. And the speaker that we have here is Dr. Shraddha Patharkar, ma'am. She is an associate consultant at ABMH Hospital, Pune. Thank you, ma'am. You can.
Yeah. Hello everyone. Last time we have gone through CCS of neurotrauma case, and some of the slides were covered in that session only, though those were from CBS. So some slides might get repeated. So we'll start with one case, and I'm hoping this is the interactive session. It's not properly not the I've not made all the questions. It's some theory part, and mostly it's interactive. So we'll start with a case. 16-year-old boy. He had gone for bicycling tour with his friends on weekend. After a while, his colleague found him collapsed on the road, for which EMS team was called for. That time his heart rate was 160 per minute, BP was 190 by 120, and he was tachypnic, he was sweaty. GCS was E2 M2 V1, pupils were 4 bilaterally sluggishly reacting to light. He got intubated at the site and shifted to nearby hospital. On arrival, his ECG was like this. So from the history and from the ECG, can anybody uh, point out what is this? I mean, what he has suffered from? You can give differentials also. It's better to give differentials.
Brugada syndrome.
Not actually.
It could be. So
Yeah,
this
but it
is
can be cardiac etiology also, considering his age. You can put differentials because he became
Um,
unresponsive. He had collapsed.
differential regarding ECG or his traumatic brain injury.
See, now everybody knows this is the traumatic brain injury topic. So definitely you'll think that way. But in my exams, we got a similar question. So many a times the UK, these scenarios are based in UK. So going on weekend parties, he's having sympathetic hyperactivity, and then he became unresponsive. So maybe he because of unresponsiveness he collapsed, or maybe he collapsed and became unresponsive. So you have to put, there might be channelopathies, there might be hypertrophic cardiomyopathy with a new ACS event, sudden cardiac arrest. Deep T wave inversions, again you can put ACS also one of the differentials, but it's not that common in such a young age. But definitely hypertrophic cardiomyopathy or sudden cardiac arrest because of some channelopathies, or the
So
ECG
the
doesn't look
patient can
tachycardic.
have drug abuse with cocaine.
Yes, yes. So probably
Couldn't
he
it
must have had,
Takotsubo disease?
you can label it as Takotsubo also. So that's what you have to give differentials. So you can put it as an NSTEMI, but for his age, it doesn't look like that. So maybe any channelopathies, hypertrophic cardiomyopathy leading to sudden cardiac arrest, or some arrhythmias and cardiac arrest, and definitely sympathomimetic drug poisoning causing stress cardiomyopathy. So what else you'll do? Now you're thinking ki this might be cocaine intoxication or LSD intoxication, some substance abuse, and then he had collapse. And ECG is such cerebral T waves. We call it as a deep cerebral T waves. So what you will do next?
We have to calm down his sympathetic drive firstly with the help of sedation, analgesia, and if required, neuromuscular blocker. And simultaneously, we have to hydrate the patient adequately.
Yeah, you always go through airway breathing circulation. Airway you have already secured.
Already secured now.
Yes. Breathing circulation, again you are thinking this might be cerebral event also. So repeated neuro monitoring, pupillary charting, you need to do that. And next step will be
Cardiac mode.
yeah, you do bedside 2D echo, see for any regional wall motion abnormality, apical ballooning. You have to again evaluate. He's a young fellow with sympathetic intoxication, so it might be some cardiac problem, or it can be because this was the case for us
Traumatic.
during our review. So you have to attend CT brain because he had this maybe because of this drug abuse, sympathetic overactivity, he might have bled in the brain. So the next slide, even in my exams, though we did not like we focus more on a cardiac, it was IC bleed. So now CT was done, and this is the picture, CT brain actual cut. Can anybody tell me what is this? What is the diagnosis?
Slide is not moving. Or slide only.
For me, it's moving. I don't know. Every time it's the problem. Now my laptop is also changed. I'll exit and I'll again.
Yeah. Now
Yeah,
it.
now.
Mhm.
So this is showing subarachnoid hemorrhage.
Yes.
Great force.
You have to completely read that CT brain, where it is, how
So
other
it is
systems.
extending in the suprasellar cistern up till the falx cerebri and the insular
Yes,
insular
even
gyrus.
Sylvian Fisher.
And
Yes.
this is thick for more than 1 millimeters. So and there is no intraventricular extension. So this is perhaps grade 3 subarachnoid hemorrhage. And
Uh, at this cut, you might not be able to see bleeding in
ventricles.
ventricle or yeah. But again, his temporal horns looks dilated. Generally, temporal horns are not very much this much visible.
So
And
might be causing obstruction.
yes, and there is flattening of sulci and gyri. You cannot make out sulci and
Cerebral
gyri.
edema is there.
Yeah, so sulcal effacement is also there. So you have to interpret CT brain thoroughly. You have to, if there is a midline shift, if there is brain herniation, dilated ventricles, compression on ipsilateral cisterns or ventricles, you have to utter all of this because every thing has a one point. Then even the bedside. Okay, CT brain was done. Now what you'll do? What will you do next?
Focus, the lung ultrasound and echo.
No. I meant for from brain point of view. Now CT brain is you got this subarachnoid hemorrhage with query obstructive hydrocephalus, and let's
So
see
we
if
will
there
give
is
the reference to the neurosurgery department first, and then we
yes,
have to take the measures to calm down the ICTs.
yes, and you have to get CT angio done also in the same setting because he's young fellow. he must have had AV aneurysm also. It might be cocaine toxicity or sympathomimetic toxicity, or reason might be underlying AV malformations also, because the management changes then. So doing CT angio, ruling out AV malformations, uh, involving neurosurgeon. Meanwhile, this, because he's young fellow with tense brain, so there is a high chance he might cone. So what you have to consider in such cases, how you will manage, and what you are worried about.
So we are worrying about intracranial hypertension. That
Yes.
is the intracranial pressure more than 20 millimeters of mercury. So we will take a set of interventions to prevent the cerebral coning. Tier 1 interventions include maintaining adequate relaxation, propped up position, and uh, relaxing the patient, giving adequate sedation. In tier 2, I would like to maintain PaCO2 35 to 30, 40 millimeters of mercury. And maybe if decompressive craniectomy is required or lumbar drainage placement is required, then I will consider that, and I will deepen the depth of sedation. In tier 3, I like to decrease the target of PCO2 to 32 to 35 millimeters of mercury, and um, I will further follow the MAP enhancement, like giving adequate fluids to this patient, increasing the mean arterial pressure to 90 millimeters of mercury. And then tier 4 is the hypothermia and thiopental coma.
See, you are partially correct, absolutely. But in tier 1, you have to utter osmotherapy.
And
Like,
external ventricular drain.
yes, very good. You have to, because see, relieving pressure in first tier itself, if you are able to do it, because that you have in tier 1, head neutral position, keeping normo, eucapnia, normal sodium levels, no neckties, head in neutral, propped up position, and sedation. In tier 2, you can go for a deeper sedation. And now our patient is about to cone. Like, we cannot wait till your pupils become anisoporic. This looks like a tense brain. So yes, and tier 1, you have to utter EVD. So because that is the most efficient way of relieving his pressure. And you should not utter lumbar drainage in these patients, because see, lumbar drainage you can do only in non-communicating hydrocephalus. Mostly subarachnoid hemorrhages are non-communicating, because the blood is there, and on the subarachnoid granulations, and then absorption of the CSF is hampered. But if it is the intraventricular hemorrhage, maybe in second, lateral ventricles, third ventricle, then it becomes obstructive, and putting lumbar drain will cone the patient. Whenever there is obstructive hydrocephalus, you have to put drain above the level of obstruction. If it is in the third ventricle, you have to put EVD, drain in the lateral ventricles. If it's a fourth ventricle, you have to put in the lateral ventricle EVD. You should not utter LP, lumbar drain, okay? Because it will worsen your patient's, it will directly cone your patient because of the pressure differentials. So in tier 1, you have to utter osmotherapy. You have to utter keeping you capnia, normal level of sodium. Uh, then if needed, decompression, craniectomy also you can go for in tier 1, if that is the midline shift is there with gross mass effect, impending herniation, then decompression craniectomy becomes a part of tier 1. Then in tier 2, you can deepen the sedation. If needed, you can give propofol. If needed, you can give muscle relaxants. Uh, Again, you can maintain low normal level of PCO2. In tier 1, you can start with 35-40. In tier 2, 30-35 you can keep till the time you shift the patient to the OT. And because again, this PCO2 washout will help only for some time, because up to 6 hours, 8 hours maybe, because then again CSF pH balances out, and your effect of uh, this your beneficiary effect on the ICP goes down. Rather, it causes cerebral vasoconstriction, and now the O2 supply to the brain is affected. Already tense brain, demand is more, and your O2 supply you are cutting off, and you are worsening the situation. So it's a temporary measure up to 6 hours, and then you have to utter. Then in tier 3, you can utter this. You have to mention normothermia, avoiding fever. These are the first modalities. In last tier, you can say hypothermia or barbiturate coma. But again, barbiturate coma, at the same time, you have to be cautious about blood pressure. You should not allow the pressures to drop. So in this case, whether is there any role of ICP monitoring?
Yes, we should monitor intracranial pressure.
Okay.
In case GCS is worsening, abnormal motor positioning, and blood pressure, systolic blood pressure less than 90 millimeters of mercury, age more than 40, then we should monitor.
Yes, you can do bedside transcranial Doppler also. Uh, uh, then you can do optic nerve sheath diameter for raised ICP. So all these measures, and but again, these are non-invasive measures, are not very accurate. You can go for invasive ICP monitoring in this case, except if it is a ALF related bleed, acute liver failure related, then putting EVD becomes relative contraindication because of the coagulopathy. But in this case, you can go for ICP monitoring. So, and again, as a part of your bedside echo screening and everything, you have done 2D echo, and this is the image. So, what it looks like?
Left ventricle is globular in shape.
Okay. What do you
EF,
call it? Apical?
Apical ballooning.
Yes,
Ballooning.
very good. So this is stress cardiomyopathy, apical Takotsubo cardiomyopathy, apical ballooning, and the reason being because of already he was on sympathomimetic agents, intoxication with that, and secondly, it's the bleeding in the brain. Such extensive bleeding can cause catecholamine surge. So
Surge.
yes, all of these can increase the afterload on the left ventricle and apical ballooning. But again, uh, you cannot differentiate completely between ACS, regional wall motion abnormality, whether it is apical hypokinesia or it is stress cardiomyopathy. But still, like in ACS, it's more of a tropi that goes up, and in stress cardiomyopathy, it's more of a NT-proBNPs. Most of the times, it's not the 100% rule, but mostly you can get that, and reciprocal changes you might not get in stress cardiomyopathy. But again, the diagnostic is angiography to rule out completely. And the stress cardiomyopathy is reversible situation. Maybe in 2 weeks or so, it gets reversed. Again, in normal ACS, you go for antiplatelets and all. Here, rather you should not give. Already patient has bled, so the management will be maybe giving reducing afterload and giving beta blockers, settling tachycardia. uh, Even diuretics, you have to be cautious, avoid hypotension. So you went for the ICP monitoring, you have put neurosurgeon side, they have put EVD. And whether if there is a, let's say there is aneurysm, whether you will go for surgery immediately for this patient for coiling or clipping. Maybe he's bled in the, if parenchyma, then they'll definitely take him for clipping. So whether that should be done, and what is the criteria, how you will decide whether to take this patient immediately for surgery or
Ma'am, patient should be taken immediate within 12 hours, because then the risk of vasospasm and other complications is higher. So the patient should be
no, I
taken.
mean, is there any criteria, like you have any scoring systems in prognostic score in subarachnoid hemorrhage?
WFNS grading, World
Yes,
Federation
very good.
Neurological Society grading. So grade 1 is when GCS is 13 to 15, no neurological deficit. Grade 2 is 13 to 15, 14, 15 GCS with neurological deficit. Grade 3 is GCS 6 to 12 without neurological deficit. And grade 4 is GCS 6 to 12 with neurological deficit. And last is stupor, coma, and confusion.
Yeah, so this Hunt and Hess, it depends on symptoms. Your WFNS is GCS and focal neurodeficits, and modified Fisher is depending upon your CT brain bleeding thickness and whether ventricles are involved. So all this, why you need to know, because lower the score, there is a high chance that patient might get benefited from the surgery. If the patient is in this, let's say he is WFNS 5, so you don't know his neurological outcome, so you should not rush such patients for the surgery. You should first see whether, see, it's not, I'm not talking about raised ICP and coning. If it's that ICP, then immediately you have to decompress. But otherwise, subarachnoid hemorrhage without raised ICP, with maybe AV malformation that has bled or something, you have to see the grading. If patient's grade is worse, you have to see whether patient is getting improved. If patient is improving, then you should if it is improving like to score 4 or 3, then you should go for surgery. But if the grading is 1, 2, 3, then securing aneurysm as early as possible is better. Okay, so ICP EVD was connected to ICP monitor, and this is the graph. Can anybody interpret it?
So P2 is higher, and P1, P2 are merged, and then there is a
Yes,
P graph.
very
So
good.
arranged intracranial compliance.
So whenever any tracing that looks like arterial trace, it looks like arterial trace, no, systolic upstroke, and there is dicrotic notch and then diastole. So whenever such picture is, it's a very catastrophic condition. When your P1, P2 are getting fused, it means brain has lost all his compensatory. Uh, it's in the steepest part of the Larson's curve. It has lost all his compensation to take any extra volume, and the compliance is very poor in such patients, and you have to immediately take measures to reduce his intracranial pressure. So again, always remember, P2 is always at least 80% lesser than P1. It should be lesser than P1, at least 80% lesser than that. So again, when you attach ICP monitor to EVD, you cannot measure it continuously, because EVD is draining CSF or blood, whatever, intraventricular blood, uh, and you cannot monitor ICP. You have to close it for some time. Every hourly, you can close it. And how much you can drain through EVD? Its maximum is 20 ml per hour. You should not drain much more than that. Otherwise, again, it over drainage can cause its own side effects. So
More than how
again,
many meals?
sorry.
More than how many meals? What's the maximum volume to drain?
Generally, they say that 20 ml per hour. In guidelines, they have mentioned they have mentioned around 3 to 5 ml every 2 to 3 minutes. So, but again, uh, you should not go beyond 20 ml per hour. At max, you can drain that. And again, depending upon EVD, they might, in EDIC, they might ask these questions or give you those scenarios. Ki patient is propped up and now patient is made flat. So what should be your target? So that you need to read uh, for EVD. And while measuring ICP, because while measuring CPP, cerebral perfusion pressure, your transducer should be at what level?
External auditory meter.
Yes, very good. It should be at external auditory meatus. Otherwise, there will be a difference. If you keep it at the phlebistostatic axis, your ICP measurement will be underestimated by almost 10 or 11. So you need to know this chart. Can anybody? Is it visible to everybody? I mean, all the ICP waveforms. Is this slide visible completely? Because this is very important slide. The
Yes,
Yeah,
ma'am.
condition.
visible, ma'am.
Yeah. So in first slide, it is you can see there are no numbers as such. But first slide, P1, P2, P3 looks normal. But if that number is, let's say, 5, 8, so the amplitude is decreased. The waveform is normal, but the amplitude is decreased. So maybe they have taken some measures to reduce the intracranial pressure. And if the amplitude is high, then you can call it as there is a raised ICP, but waveform is normal. So normal waveform means P1 is always bigger than P2 and P3, and second bigger wave is P2. So can anybody tell me what is P1, P2, P3?
P1 is percussion wave, which
Mhm.
correlates with the arterial pulse, and
Yes,
P2 is
start
the
of systole. Hmm.
tidal,
Plexus.
which correlates with the cerebral compliance and the intracranial pressure. And P3 is the dicrotic wave, which correlates with the aortic valve fusion.
Yeah, so at the start of arterial pulse, the start of systole is your P1. When blood flows through choroid plexus, that produces the whatever the pressure it gives on the wall, that is P1. P2 is that pulse transmitted from the brain parenchymal tissue. That is your P2. That's why whenever P2 is going up means brain is non-compliant, it is rigid, and that pressure, transmitted pressure will be high. So P2 goes up. And P3 is your dicrotic notch when aortic valve closes. So whenever there is an increase in CSF volume, maybe because of some obstruction or maybe because of increased production because of some papillomas and choroid plexus papillomas, there is a increase in the amplitude of all these waveforms. And when you drain through EVD, there will be decrease in the amplitude. And even a low amplitude might be seen when there is a missing bone flap, when they do the decompression craniectomy and they remove the flap. That time also waveform looks normal, but the amplitude reduces. Then in second graph, you can make out that P1 is much higher than P2, P3. So ideally, P2 should be around 80% of the P1. But here, the P1 is quite taller than P2, P3. It indicates systolic BP is quite high. And the ICP trace looks like your arterial line, more of a arterial line. So even when the systolic BP is high, that can be the Cushing's response. Maybe when patient's autoregulation is still intact, body is trying to increase blood pressure to reduce ICP. We'll see the correlation in next slides. In third graph, you can make out that all P1, P2, P3 height is reduced. No, sorry. P1 height is reduced. P2, P3 are at the same level, but the height of P1 is reduced. It indicates systolic BP is low. And even that is not good because your cerebral depends on that. So when P1 is height is much lesser and it is equal to P2, then you can think of systolic BP is low. And in fourth graph, again P2 is bigger than P1, so it is non-compliant brain. So maybe some mass lesion, hydrocephalus, raised ICP because of any of this. In fifth graph, you can see that height of P2, P3 is much more diminished. And that happens when you are hyperventilating the patient. Whenever there is a cerebral vasoconstriction, and because of vasoconstriction, cerebral blood flow is reduced and the cerebral blood volume is also reduced. So compliance of the brain gets better, because now tight brain doesn't have to deal with that increased volume. Because of the constriction, the cerebral blood volume is low. So they might show you this graph. Initial graph was maybe like non-compliant brain, and the second graph is like this. So what they have done is they have hyperventilated the patient to the OT to buy some time. And the last graph is, it's detrimental, that I have shown you before. P1, P2 are merged. It's very critically high ICP. So again, you should know Lundberg's waves, A, B, C. A is pathological, and actually these are not waves. There are multiple ICP wave, P1, P2, P3. Over the time, they look like this. And again, Lundberg A wave indicates that it is transiently increased. Normally, up to 20 minutes, body can tolerate that much of a raised ICP. If patient is bucking, coughing, then plateau A waves will be generated, but those are for the short duration. And again, when it is coming down, it means that your autoregulation is intact. When plateau waves are there and it is going up to very high ICP, maybe 60, 80, and it is staying there for 15 minutes and then again coming down, it means your autoregulation is intact. But again, this plateau wave, if they remain longer, then it's not good. Then patient will have reduced cerebral perfusion pressure. Uh, then again, you need to read about Lundberg's A, B, and C. C are physiological waves, depending upon your respiratory cycle and cardiac cycle. And B are again ICP up 20 to 40. And if very high ICP, they are A waves. Again, what are the modalities to measure ICP, and which is the gold standard? Can anybody tell me quickly?
We can have invasive and non-invasive modality. In invasive,
Okay.
we can monitor with the help of EVD, intraparenchymal monitoring, then subarachnoid bolt, and then in non-invasive, again we can go for just brain tissue oxygen, then jugular vein saturation. These all are invasive modality. Non-invasive modalities are TCD, then ONSD, and
NIRS.
NIRS.
Okay, good.
And gold standard is, ma'am, EV, external ventricular device.
Yes, very good. Why it is gold standard? Because
We can drain also and monitor also.
yes, but the side effect is
Side
disadvantages.
effect, there is a chances of infection if we don't handle the EVD. There is a chance.
Bleeding and infection, both.
Both.
Yeah, and parenchymal and even EVDs, they are difficult to put when ventricles are compressed. When there is a mass effect and ventricles are compressed, then it's difficult to put. Parenchymal, like in this picture, they might, for EDIC, they will just in table, they'll show you this and they'll ask what are the advantages or what are the disadvantages of this. So you need to know what is this. So one is the Codman catheter. The left one, they have mentioned Camino. These are intraparenchymal catheters. Both Camino and Codman's, they are parenchymal, intraparenchymal. And they are easy to insert, less chances of bleeding, infection. But again, drift is there. So less accurate reading as compared to EVD, and you cannot drain CSF. So how you have to just go through some pictures, Camino and Codman and the various microdialysis catheters. They might just give you one slide and they will ask questions on that. So you need to understand this auto-regulation. Can anybody tell me what is the concept of auto-regulation? What is the concept?
Cerebral blood flow is constant over a range of systolic blood pressure from 50 to 50, 150 stable perfusion pressure. This blood flow is maintained in a constant range. Above that, there will be cerebral hyperemia, and below that,
Yes, so between 50 to 150 of cerebral perfusion pressure, there will be constant cerebral blood flow. So over a wide range of a perfusion pressure. So over a wide range of even mean arterial pressure of 50 to 150. But if it goes below that, then autoregulation is generally lost and they become pressure dependent. If there is a high pressure, it causes hyperemia, vasogenic edema, and if there is a low pressure, then it causes ischemia, infarction, and hypoperfusion. But then this autoregulation curve shifts towards right in old people because of their long-standing hypertension. That's why in such patients you might need to keep BP little on a higher side, you compared to younger population, and you have to maintain CPP. That's why there is a concept of CPP optimal CPP. It's though brain trauma foundation guidelines, they say keep CPP more than, what is the British trauma brain trauma foundation guidelines target?
60 to 70.
70
Yes,
millimeters of mercury.
yes.
70.
uh, but again, depending upon, you have to see what is the optimal CPP for that patient. And you have to consider effect of PCO2 also. Why this hyperventilation and all is important? Because between 20 to 80 mm of SG, uh, if it is towards 80, if PCO2 is towards 80, there will be maximum vasodilatation. And if it is 20, there is a maximum vasoconstriction. Beyond that, there won't be any effect. So it's better to keep 35 to 40 PCO2 for a optimal cerebral blood flow and blood volume. Otherwise, excess PCO2 will cause excess of vasodilatation, cerebral blood flow will increase, cerebral blood volume will increase, and it will worsen your ICP. So keeping PCO2 35 to 40 is very important. Again, now cerebral autoregulation, though I'm sorry for slides, this is not very clear, but I will tell you what is that. In whenever there is an intact autoregulation means what? Your cerebral vasoreactivity is acting properly. So whenever BP is going up, so we don't want that much of a blood flow to be in the brain in that area. So cerebral blood vessels vasoconstrict to avoid that excess of blood when the BP goes up. And when the BP is down, we brain wants more blood, so vessels dilate to perfuse that area when the BP is low. So this is the vasoreactivity. So whenever they properly react, then it is the intact autoregulation. So when your BP is going up and your ICP is coming down and your CPP is maintained, then you call that intact autoregulation. But when you are increasing BP, your ICP is going up and your CPP is also going up. That is your impaired autoregulation. You are understanding this concept because they will give you one of the graphs and they'll ask you whether the autoregulation is intact or not. So that's why we give map challenge whenever ICP monitor is in situ to check whether autoregulation is intact or not. So when by giving map challenge, you are trying to increase blood pressure by 10-20% using NORAD. And if by increasing blood pressure ICP is coming down, it means your autoregulation is intact. But if you're by increasing BP, your ICP is also increasing, your CPP is also increasing, but your that means that autoregulation is lost. You are understanding this concept? Otherwise, read about.
can you
See, normally CPP is what? MAP minus ICP.
Mm-hmm.
So when normally CPP is over a wide range, like 50 to 150, uh, even if CPP is quite high, your cerebral blood volume flow tries to remain in a constant limit because of vasoreactivity, because of vasoconstriction, vasodilatation. That maintains your autoregulation. So instead of CPP, you consider now arterial BP. When arterial BP is going up, normally what should happen? CPP should go up.
Mm-hmm.
And but normal जब ऑटो रेगुलेशन इंटैक्ट होता है तो सीपीपी रिमेन्स कांस्टेंट ओवर अ वाइड रेंज. Over a wide range, CPP will remain constant. When you are increasing BP, your ICP is going down. Uh, your cerebral blood flow divided by your CPP divided by vascular reactivity is your cerebral blood flow. So when CPP is going up, your cerebral blood flow will go up. When vasoconstriction, your cerebral blood flow should go down. You just remember two formulas. CPP is MAP minus ICP. Cerebral blood flow is equal to CPP divided by cerebrovascular resistance. So when CPP is going up, your cerebral blood flow will increase. That is also not good. We don't want. We want CPP to remain constant over a wide range. And when I'm increasing blood pressure, my ICP is going down. This means auto regulation is working, vasoconstriction karna and all. So my auto regulation is intact. That's why my cerebral blood flow is still remaining constant. अगर बीपी ऊपर जा रहा है, आईसीपी कम हो रहा है, auto regulation is intact. If BP is increasing and your ICP is also increasing and CPP is increasing, means blood flow excess में जा रहा है, then your auto regulation is lost. It's a very easy concept. You can read about auto regulation because one or two graphs, at least one graph they might put for this. Again, in non-invasive methods, pupillometry, it's just remember this much. Normal pupillary response to the light is 35 to 36% decrease in the size. When and there is one index, this NPI index of pupillometry. So it will take consideration of size of pupil, how quickly vasoconstriction and vasodilatation occurs, all of that, and there is a number. When that NPI number is less than 3, then it is okay. If it increases, uh, it indicates raised ICP. Again, just NPI, you can search and they might just show you this device and they will ask what is this. Again, in multimodal neuromonitoring, I don't know whether you can see this or not because it's not in slide share mode. There is a Lycox monitor. Even that you just Google and see how it looks like. That has a PBTO2, that is a brain tissue oxygen monitor. What is the normal range for PBTO2?
60 to 80%.
No, PBTO2. It's a brain tissue oxygen tension. It's in mm of Sg. It should be more than 20. 15 to 20 is reduced, it might cause ischemia. Less than 10, irreversible brain damage. So PBTO2 is partial pressure of oxygen in the brain tissue at that point. So Lycox monitor, it measures your ICP, your PBTO2, temperature. So that 3 modalities you get in that one monitor. So again, microdialysis catheter, you just search these names and how they look like. They will ask 1 or 2 questions. What is the importance of PBTO2? When you are hyperventilating patients blindly, patient might have vasoconstriction and because of that, O2 supply to that region of the brain will be affected. So if you have PBTO2 monitor in C2, so you can hyperventilate till the point PBTO2 is beyond 20. So more than 20 is our target. That oxygen, it means oxygen tension in that area is adequate. Then only you can hyperventilate. Otherwise, if that is getting compromised, you are hampering more by doing hyperventilation. So again, jugular venous oximetry. You put it in the reverse way. In central line, you through IGV you put towards heart. Here you put ulta from jugular vein into the bulb. The tip is above the C1 vertebra, lower border. So it gives one-sided jugular vein bulb. It drains 70% of the same hemisphere and 30% from the opposite hemisphere. So that is this is also very important. It tells you about the global oxygenation of the brain tissue. PbTO2 will tell you the local oxygenation, where you are putting that monitor. There in the insulted, around the insulted area, there it will tell you the O2 tension. This SjVO2 will tell you the global how much is the O2 supply to the brain and how much O2 is utilized by the brain. So it tells you about that. It's like your ScVO2. The factors which will decrease and increase ScVO2 and SjO2, they are same. So, and what is the normal range of SjO2?
Jugular venous, na ma'am?
Yes,
60
oximeter.
to 80%.
Yes, it should be beyond 55%, up to 75%. Beyond 75% also, it's not good. It's similar to ScVO2. If beyond 75% means you have to find out whether brain activities slowed down because of sedation, maybe anti-shivering medications and everything you have given, or whether the brain tissue electrical activity has gone, patient is becoming brain dead, not utilizing it, and that's why SjVO2 is high. And if it is low, it means maybe electrical activity, fever, patient is coughing, bucking, stimulus. So similarly, as ScVO2 के जो factors है, those who are increasing and decreasing, similarly jugular venous oximetry का भी वो factors, and these are very important. Our 1 or 2 slides are questions are based on this. So again, ICP and PBTO2 helps you plan your treatment. So you just read about what is the correlation between these two. Sometimes just having optimal CPP is not, as I told you, optimal CPP differs. So that's why this regional oxygen saturation in the brain, NSRI, it is also very important. Many times maybe your CPP is 60, 70, but like in this graph, though the CPP looks okay, your regional oxygen in the left and the right, you see that it is dropping. Even your saturation looks okay. Your patients may be saturating 98%. Your CPP is 60, 65 or 70. Still, the regional oxygen supply to the brain is inadequate. That's why multimodal modalities, they are important. So again, they will show you this picture, a monitor with brain picture, and there will be number SO2, regional SO2, right side, left side, 70%. So normal range is 65 to 70%. It should be that. NIRS, you can use NIRS for other things also, like not only for traumatic brain injuries, subarachnoid hemorrhage, acute ischemic stroke, but in cardiac surgery, carotid surgeries, thoracic surgeries, aortic aneurysm repair, sometimes in your this VA ECMO, when you are putting perfusion cannula distally. So just to check whether the limb is getting perfused properly or not. So NIRS have many, you need to know how it looks like, and then they'll ask you 1 or 2 questions depending on it. So another modality is transcranial Doppler. This also you need to read it thoroughly. I have not covered much, but towards the probe, flow will be upright. Away from the probe, it will be down. at what distance what vessels you get. Generally ACA is the reverse flow, MCA, PCA are the upright flows. When there is a bifurcation of the flow, I mean both biphasic, upright and down also, then it is the junction of MCA, ICA. So just go through how all these waveforms look like. And in subarachnoid hemorrhage, what is important in TCD? What you look for?
Lindegaard's ratio, which is
Yes,
mean
yes,
MCA velocity divided by mean ICA velocity.
yeah,
So if it is more than 3, then it indicates a vasospasm, and less than 3, then cerebral hyperemia.
yes. So you need to know what is the mean flow velocity and what is the peak systolic velocity, end diastolic velocity. So then you can calculate pulsatility, Gosling's pulsatility index. That gives you idea about ICP. So Lindegaard's ratio and the mean flow velocity will tell you about vasospasm or hyperemia. If there is a very high velocity can be there in both hyperemia as well as vasospasm. But Lindegaard's ratio less than 3 is in hyperemia. Beyond 3, it is vasospasm. And pulsatility index also. Just in ultrasound book, there is a chapter on neuroimaging, neurosonography. Just read that 4 pages chapter, but it will cover everything from raised ICP to this Gosling's index. It is needed to uh, if it is beyond more than 1.24, then it indicates ICP is beyond 20. It's a non-invasive way of uh, ICP monitoring. So the next question is, so for his raised ICP, osmotherapy was ongoing, and after 48 hours, his urine output was 200 to 250 ml per hour, and 1000 ml in the next 3 hours. So he is polyuric. So labs were done. Electrolytes were showing sodium of 144, potassium 5.5, urea was 30, creat was 1.1, serum osmolarity is 330, urine osmolarity 322. And what is the reason for his polyuria in this case?
Central DI, diabetes insipidus.
Okay, that can be the possibility, but what is against central DI?
Mannitol osmotherapy leading to high serum osmolarity and polyuria.
Yes, very good. See, why it is not DI?
Because urine osmolality is
No, serum sodium is normal.
serum osmolality is
DS, it should be hypernatremia.
Should be hypernatremia, but maybe patient's initial sodium was 130 and now it is 144. You don't know the previous reading of sodium. But one more very important thing that to differentiate that this is not DI. In DI, urine should be very dilute. So your urine osmolarity it should be less than 100. Your urine osmolarity is 320, which is normal. Because in DI, the mechanism is there is ADH is is not retaining. There is no adequate ADH, so patient is not retaining water. So he is losing free water. So the urine is very dilute. Urine osmolarity should be less than 100. And another thing is, here you see you have to utter osmolar gap. What is the osmolar gap here?
Twice of sodium, 288. So 330 minus 288. It's elevated here. I mean,
Yes, very good. So osmolar gap, how to remember? MC square. So it's like measured, MC is measured minus calculated. So first you have to take the measured number and you have to minus calculated from. Measured is 330 and calculated is twice the sodium. So 144 into 2 and you have to minus it. So when it is beyond 10, 20, it is hyperosmolar. There is osmotically active substance. So either it might be mannitol or what can be the other possibility?
uh, IVIG, hypergamma globulins therapy, or
Ethylene
For this
glycol.
case,
Normal
for
saline. Normal saline.
no, normal saline will not.
3%
3%,
NaCl, ma'am.
3%.
Okay, yes, that can be the possibility. And another possibility, young fellow, he must have
Hypertensive.
had alcohol also. So, but now this is after 48 hours. But if immediately alcohol is also active osmol, no? So the alcohol intoxication, methanol toxicity, they also increases osmolar gap. So that also, whenever they have given osmolarity, keep in mind to calculate osmolar gap. So in the same patient, when ICP was measured, it was 35, MAP was 90. His SgVO2 was 50%, and arterial pH was 7.55, PCO2 of 27, PaO2 was 95, and saturation was 99%. What it indicates and how to manage it.
So this is intracranial hypertension because it is more than 20 ICP, and SjVO2 is also reducing.
CPP,
CPP is MAP minus ICP, 90 minus 35, 55. So it is
yes, it's a low CPP.
low CPP.
SgVO2 is
This is also low, and
hmm,
ABG is showing respiratory alkalosis.
See, I've already told you that whenever SgVO2 indicates the global oxygenation of the brain tissue. When already oxygen is low, and what is your arterial pH? It is 7.5. It is alkalotic, and it is whether it is it looks like respiratory alkalosis. I have not mentioned bicarb here, but it looks like respiratory alkalosis. So you need to reduce your RR on ventilator, because whenever oxygen SjVO2 is low means brain oxygen is low, and by hyperventilating you are vasoconstricting his cerebral blood vessels and you are injuring brain even more. Already there is a oxygen deficiency in that region of the brain, and by vasoconstriction you are worsening the condition. So it indicates SgVO2 indicates decreased O2 tension in the brain tissue, or O2 supply to the brain, and that reason might be severe cerebral vasoconstriction. So we need to reduce the RR and keep the PCO2 maybe 35 to 40. So as same patient with a MAP of 110, heart rate is 45 on deep sedation, bilateral pupils 4 not reacting. Now the SgVO2 is 80% and the ABGPO2 is 100, PCO2 is 58. What it indicates and what should be the next step?
So heart rate is reducing and MAP is high. So this is perhaps Cushing's reflex, which is suggestive of raised intracranial pressure. And the SjVO2 is also high. So that means the brain is perhaps not using enough oxygen, and
Very good.
because of perhaps deep sedation also it can be this.
Yes, it can be because of deep sedation. It can be because of brain activity. Maybe now electrical activity of the brain is
Le-
uh, gone, or maybe patient is coning and going towards brain dead. And second important thing is patient's PCO2 is also high.
is high. So this
So
is
even
perhaps
that causes
respiratory center is involved now.
the vasodilatation. That this can itself can increase ICP. So you have to again adjust your ventilator settings to make PaCO2 35 to 40 and see whether SgVO2 is uh, getting better. Uh, Otherwise, you have to do bedside optic nerve sheath and other non-invasive measures. Or else you have to rush patient to the
CT room.
yes. And this was the CT.
Cerebral edema.
What is this?
So there is a diminution of the gray-white differentiation, which
Right.
is suggestive of cerebral edema in this patient. and which is corroborating with the findings of raised intracranial pressure.
Yeah, and you cannot see any ventricles. You cannot see any cisterns. So there is a sulcal effacement. Cisterns are compressed, and there is
And
this
there's subarachnoid hemorrhage.
there is some structure, white structure in the um, right side of the brain. There is that
Vein,
is your,
transverse vein,
that is your uh,
sinus.
And
it doesn't
atheroma.
look like EVD tip. Maybe EVD should be much in the central area, but many a times if this is the picture in the center, the you're just able to see the EVD tip. Ventricles are completely effaced because of the gross cerebral edema, and this is the terminal stage where you cannot make out any brain structures. So probably patient is brain dead. But again, confirmation is by what is the gold standard to confirm?
CTA angio. And
Yes.
after that, there's the clinical.
Yeah, clinically you can. But in CT room, anyways, you have gone and you have seen such CT brain. Better you do CT angio. If in CT angio, if there is no intracranial vessels filling, but the extracranial vessels are still filled, it is the gold standard to diagnose the patient is brain dead. And maybe meanwhile, ultrasound, even bedside ONSD was showing this. That also indicates raised ICP. They have mentioned diameter is 6 mm. So they might show you this figure with 6 mm. It indicates raised ICP. Many a times there is a bulge on the at the globe, and where the at the retina behind at the globe. So that bulge indicates papilloedema. So whenever your optic nerve sheath diameter more than 6 mm, it indicates ICP is more than 20 mm of SG. But many times it is between 5 to 6. It's not completely beyond 6. So, or maybe 4.5 to 5. In that case, you can use this disc bulge as a raised ICP sign. And again, this is in last CCS also I've shown you this picture. This is very important slide. uh, on Doppler, in first graph you get the upstroke, that is systole, and then it is the diastole. This is the normal flow. When there is an increase in ICP, your systole is preserved, but your diastole is getting, I mean, this curve is getting down. It means that end diastolic velocity is going down, and peak systolic velocity is still maintained. So forward flow is still maintained. In graph C, the systolic flow is there, systolic velocity is there, and now there is no diastolic velocity. When your end diastolic velocity becomes equal to ICP, then this picture occurs. But again, there is a forward flow, at least because peak systolic velocity is still there. In graph D, there is forward flow is there with the systole, but there is a reverberating flow. So but still that backward flow is small, so still forward flow is, some forward flow is there. So in this ABCD 4 graphs, you cannot label patient as brain dead. But in the rest 3, in here the peak systolic is equal to your backward reverberating flow, so net flow is 0 because they are cancelling out each other. There is no net flow in the brain. In F, these are all on transcranial Doppler, okay, these velocities. In F, there are only short systolic peaks. Again, this indicates there is no flow in the brain. And G is there is flat line. All last 3 indicates cerebrovascular arrest. So you can use this as an ancillary test for the brain death patient. Similarly, this is the same slide. They might show you maybe slide 2. Here only the systolic peaks are there, short systolic peaks. Again, this is not consistent with blood flow, forward flow in the brain. And in brain, for more than 7 minutes, if there is no O2 blood supply, there will be permanent damage to the brain. So just read through various ICP waveforms, various both non-invasive and invasive monitoring of ICP monitoring devices. Just Google these Lycox monitor, Codman, and any other devices that you get online, because most of the times we are not using these devices. But at least go through pictures. They'll just put one picture and they'll ask some question on it, so you need to identify what is that. And go through scans. And how to read scan, you have to completely read the scan, whether mass effect, midline shift, intraventricular extension, any bony fractures, pneumocephalus, all of that you need to. And you need to know the significance. If it is at the temporal area, uncal herniation, subpalcian herniations, all these images might be kept in the exams. And there will be 1 point for each finding. So the more you will talk, cover the findings, you'll get the complete points. Okay, we'll finish here then.
Thank you, everyone.